Grant, thank you very much for inviting me. It's always a great pleasure to come back to Copenhagen. It's one of our favourite cities in the world. Last time I spoke to a mixed audience of Swedes and Danes. The Swedes were all on one side of the room and the Danes were all on the other side, so it's great to see everybody a bit mixed up today. Shows some unity across Europe, even if we aren't. I kind of like speaking to in the Nordic countries and get very nervous at the same time because it's a great place to visit, great friendly people, but you're also very skilled and very knowledgeable in the field. So I always feel under pressure to up my game a little bit. So hopefully I live up to the very kind introductions that were done. The talk's going to be in two halves. So the first one really is to look at some of the background to atopic dermatitis, some of the new findings, trying to bring in some of the microbiome stuff from Aline, and discuss how that's influencing the way we manage and treat this disease and our treatment choices. And then I've also just picked out a few topics where I see the same mistakes being made over and over again in the cases that are referred in to me. So forgive me if you're already familiar with some of those, but I thought it was important just to bring them in and show where some of the evidence for that is. And then the second half of the talk will look at the way we're exploring treatment and bringing together what we're learning about the pathogenesis of this disease and the evolution of this disease into how we can make the best treatment choices for our patients, because in many ways treatment now is much easier. So when I was a young dermatologist, we basically had essential fatty acids, some shampoos, immunotherapy, antihistamines and steroids, and that was about it. And now there's a vast range of different and safe and highly effective products, but the challenge is how we use these to the best effect, because they're not the same and they have advantages and disadvantages, and we need to treat each animal as an individual. And I'll go through some ways we're beginning to think about how we best use those treatment choices to support our patients. We have a tradition amongst the students of Cake Friday, and some of them will make a great deal of effort to bring in some nice cakes for us. And this one here, we'd seen a Westie with ichthyosis. So one of the students pitched up with it, and it tasted as good as it looked, although it was a shame to actually cut into it in the end. So if you look up the original definition of atopic dermatitis, it said it's a chronic inflammatory disease most commonly associated with sensitization to environmental allergens. And that I think is old, it's inaccurate, it's misleading, but it's still current. And one of the problems with that is that a lot of veterinarians, certainly in the UK, and a lot of owners will focus on this being an allergic disease. They'll rely on allergy testing for diagnosis, and they'll focus in on the allergy as the sole trigger of the disease. And I love this definition from Emma Gutman-Lasky, who's one of the world's leading researchers into atopic diseases in humans, because it says what it is, really. It's a chronic, lifelong inflammatory disease, but it is reversible with treatment, but not curable. And this is a gross simplification of the condition, but it's showing that it's a very multifactorial problem. And what I like about this diagram is she's not implying where it starts. So there can be different start points and different collections of triggers for different individuals, but once it gets going, it becomes this cycle of alterations to the microbiome, and you had a lot of that a couple of years ago with Aline. There are changes in innate immunity, both acute and chronic changes. There is allergic sensitization for sure, but it is only part of the disease, and some animals don't have an allergic sensitization, and that can be to food or environmental allergens or both. There's a strong genetic predisposition, and then we possibly have the environmental and lifestyle factors as well. And in diagnosis and treatment, we have to identify as many of these triggers for each individual as we can, and then put together a program of treatment that addresses them. And in terms of the genetics, I mean, there are very strong breed predispositions to this disease, which are well recognized. And the only one I'd kind of point out here is the sighthound group. It is rare for me to see atopic dermatitis in the sighthounds. I get other problems, but that's one of my few greyhounds with the disease. But it's very common across a whole range of breeds. But the inheritance here is polygenic, so it involves multiple different genes, and it's very complex because they're all inherited and exert their effects in different ways. So I think trying to identify the gene that causes the problem and look at genetic testing is going to be very difficult, if not impossible, with this disease. Now again, this is one of the best inheritance studies that was done by Stephen Shaw, looking at British guide dogs. And again, you can see a very, very strong genetic trend towards the inheritance of this disease, but it was variable and it's not absolute. And we also know that this is variable between different breeds as well. And for instance, we found that golden retrievers, have abnormalities in the filaggrin gene, which is important skin barrier protection. But we found that in multiple studies in the US, UK, and Australia that Westies don't. So they have a different background to the disease. We also found that golden retrievers had a different genetic background in the UK compared to golden retrievers in Japan and the US, suggesting, again, that both between and within breeds, that a genetic background to this disease can be different. And then this study, which was led out by Claude Favreau and has become very widely cited and rightly so, showed that there are phenotypic differences between different breeds, which from our genetic studies we could have probably predicted. And so you've got the golden retriever and the boxer here, which are tending to be the more typical atopic, with the ears, extremities, flexor surfaces, and so on. But again, they're different. Boxers, heavily facial involvement here, but we're not tending to see that in the golden retrievers. And then the German Shepherd dog here has a lot of neck and lateral limb involvement. Now, in other breeds, lateral limb involvement in itch would suggest to me that the animal potentially has sarcoptes, but not in a German Shepherd. And then the good old Shar-Pei basically doesn't do anything to help us because it can have lesions anywhere. And there's just some more here. So again, Dalmatian, Labrador, and Jack Russell Terrier, perhaps a sort of typical atopic dog. The French Bulldog, very face-oriented. And the Westie, again, lateral limb, but the back tends to be involved there. Now, in other breeds, that's a strong marker for flea allergic dermatitis. So suggesting that the genetic background and the disease may be subtly different between these different breeds. And this was a study presented at the European Allergy and Clinical Immunology meeting in Helsinki a few years ago. And the complex analysis in this paper was way above my head. I tried several times to read it, both sober and not. And the take-home message here is that they looked at several thousand patients with atopic eczema. And remarkably, what they were able to do is look at the clinical presentation, responses to treatment. They looked at the metabolome. They looked at the genome. So lots of omes were analyzed here. And then using some very complicated statistics, they actually managed to group these patients into 4 somewhat overlapping but distinct groups with different immunology, different clinical phenotypes, and the authors were saying likely they will require different approaches to treatment. And if we go back one step, it is likely that we may get to the stage where we're looking at different breed-associated and certainly phenotype-associated treatments, because one thing is not going to work for every patient. There is a strong environmental influence as well. This was some of the landmark studies that were done in Switzerland and Sweden on this. Later point out. The red are risk factors, the green are tended to be protective factors. And if you look at these, the authors were speculating that these can have effects on immune function, skin barrier function in likely genetically predisposed individuals, which governs the onset of their disease. But the strength of the effect very much varied with breed as well as lifestyle. Now, I won't spend a lot of time on the skin barrier function, and there's still a lot of debate about whether or not this is as a consequence of the disease or it's a primary factor in the disease. And again, this may vary between different breeds. And one interesting factor here is that the altered filaggrin expression, I say at genetic level, we found it's very strongly associated with golden retrievers, which often have a very dry skin phenotype of atopic dermatitis, but not Westies, which tend to have a much more seborrheic skin phenotype with atopic dermatitis. So whether that's involved, I don't know. But certainly in humans, management of the skin barrier is very important as a baseline of therapy from the very early stages of atopic dermatitis, both in infants and adults. And you're going to hear more about that later on today. But one thing we will be looking at both when I come to talk about treatment is that acute disease and chronic disease are very different in terms of the cytokine patterns, the cell recruitment, and the proliferative changes to the skin and associated structures. And we have to treat these two phenotypes very differently. So what's going to work for this dog is not going to work for this dog. And our eventual aim of treatment is to take this one and move it to this, and then use proactive treatment to keep it there. And that's why we're kind of in our little infancy, really, with how we go about that. And at the very end of this morning, I'll present some options or ways that we can look at that to make sure that we individualize our treatment, make it appropriate for the patient. So this is Thierry Olivery's, again, landmark paper from Journal of Investigative Dermatology. And this was looking at the expression of different inflammatory and pruritic pathways in experimentally sensitized dogs in a time-dependent fashion, and very much showing that acute atopic dermatitis is heavily skewed towards these Th2, T helper 22, and in particular the IL-31. So that's the cytokine there, that's the cytokine receptor pathways. And this is starting to show targets for intervention. Now, what we now know is that in chronic disease, the cytokine pattern changes here, and it becomes a much more mixed inflammatory pattern with the involvement of T helper 1 cells and T helper 1 pathways. We also get T helper 17 coming in there as well. There are proliferative changes taking place. There are alterations in innate immunity. Keratinocytes are an immune active cell and will release lots of pro-inflammatory cytokines and other mediators. We wind up with the neuronal stimulation, an increasing opening up of different itch and inflammatory pathways. And this is why chronic disease is much more severe and much more complicated and much more difficult to manage when you get to that stage. And I'll mention proactive versus reactive treatment several times as we go along this morning. But if we only do reactive treatment to manage the flares, we're not managing this ongoing cycle, and over months to years, we will wind up with chronic disease. If I go back, so if we don't proactively manage the dog at this stage, some years later, we will be there, and that is much harder to manage and has a much bigger impact on the dog's quality of life and the owner's quality of life as well. There we go. Now, one of the things that's become popular, or I hesitate to use the word fashionable because it seems like it's wrong and ephemeral, but it's become a great area of interest, is the role of regulation. Because I think you can boil atopic dermatitis down to the fact that it's a disease of a failure of regulation. The immune system and the skin should not be responding in this way, because if you're a healthy individual, human or a dog, your skin is pretty tolerant to the outside world. It might have the odd itch, the odd flare of inflammation, but it doesn't really respond. But given the same influences, atopic skin is responding inappropriately, as though there is a big threat. And the regulatory system seems to be at fault here. And certainly studies have shown that at successful allergen-specific immunotherapy, and there'll be more about that later on today, is associated with upregulation of these regulatory pathways. So a lot of interest now is moving towards, well, what is failing? What is failing about the regulation? What isn't working about the acquisition of tolerance? And this is somewhere where the microbiome studies have become very important. And again, at the moment, we're not entirely sure whether the changes in the microbiome are a primary factor or as a consequence of the atopic dermatitis. And I would put money that they're probably both, because again, this is a complex, evolving circular disease. But certainly a healthy microbiome at all parts of the body is very important in maintaining a tolerant and healthy immune system and homeostasis. And this was a study published in 2012 by Heidi Kong colleagues in the US, and again was a groundbreaking study. And what they did here was took a series of healthy children, and I think that's about 12 atopic children, and they looked at their skin microbiome. So I basically, don't worry too much about the figures here, but the more colors here, the better, because that means your microbiome is more rich and even and diverse. And in general, when we talk about bacteria, the less diverse the microbiome, that's bad. So a diverse microbiome is healthy. So you can see already the atopic children don't have quite a diverse microbiome as the healthy children, and in particular it's skewed towards the staphylococci here, which are the pinky ones. Now when they have a flare, it overwhelmingly becomes dominated by the staphs, and then when they're treated, what happens is that we don't get rid of the staph, but the microbiome becomes more diverse again. And this is just another way of looking at the same data here. And in this time, all the grey bars here are the non-staph bacteria, and the ones to focus here are the pink ones, which are Staph aureus. So some of these non-coagulase positive staph here might actually be protective against the Staph aureus, and I'll show you some interesting work on that a little bit later on. And you can see that actually the Staph aureus makes up a very small part of the normal healthy human microbiome, little bit more in the atopic children, and again overwhelmingly in the flare. So they're contributing to the inflammation, and this is what we would have traditionally called a secondary staphylococcal infection or staphylococcal pyoderma. And again, they're being knocked back in favor of the coagulase negative species when the treatment is done. Now, again, going back to proactive and reactive therapy, what this group were also able to show is that the children who had no treatment between flares, so these children were just on reactive therapy, they waited till they had a flare, then they were treated, had a much less diverse microbiome than those children who were on intermittent proactive therapy between the flares. And in fact, in those children, the flares were less frequent and less severe than in the reactively treated children here. And certainly now proactive treatment of childhood eczema is very strongly recommended in all the treatment guidelines. Now, there's been a huge number of papers, and I'm not going to spend a lot of time on this because I think Aline probably covered this in great detail in her talk, beginning to look at the microbiome in all sorts of different places and situations in dogs. And I've just got a couple of tables that show, this is a fairly recent one, and they were looking at the bacterial and fungal microbiome here. And again, what you see is this very strong association with the staphylococci and related bacteria here with an atopic status compared to a healthy status. Now, interestingly, when they looked at the fungi here, there was much the association with the atopic state was much less clear, and we don't quite understand this, but it may be that atopic skin is actually associated with more virulent Malassezia strains than healthy skin is, and this could be due to changes in the skin barrier and changes in the skin lipid and ceramide structure, and those are skewing the Malassezia population towards these atopic adapted strains, which actually produce more pro-inflammatory enzymes such as phospholipase and so on. So the story with Malassezia may be a little bit different from the bacteria. Now, this is work done by Charles Bradley at the University of Pennsylvania. And again, this is where I think we need to start thinking again in the way we talk and think about infection, because traditionally we would have called this a secondary staphylococcal pyoderma or a secondary staph infection. And the problem with that terminology is if we use the word infection, it implies it's been acquired like flu. It implies that it can be treated. It implies that you'll get over it and that it's gone. And what we're beginning to learn from the microbiome is that that isn't true. So again, this is a very similar study. This is atopic dogs. Sorry, this is the healthy dogs. And again, lots and lots of colors here. This is the atopic dogs. Now, these have presented with a flare associated with what we would have called a staphylococcal infection. And you can see the staph skewing here. And then as these dogs are treated with the antibiotics, you can see that the staph goes down but is not eliminated, and the normal microbiome begins to restore itself there. So I think really what we're dealing with here is what we would call a dysbiosis rather than an infection. I don't know if that term's ever going to catch on, but it would be very useful because it would school us to start thinking about how we manage a normal microbiome rather than just keep using antibiotics to treat an infection. And also would explain why it keeps coming back despite therapy. So when I was a young dermatologist, and there's probably a few people of my era in this room, we were taught to give atopic dogs prone to secondary staphylococcal infection cephalexin on every Saturday and Sunday. And what we now, and it worked. I mean, there's no doubt about it. It worked. It was, and I remember, and I won't name names because we were all guilty of this, but I remember being in a lecture and a very eminent dermatologist saying to the audience, you can regard cephalexin as a steroid-sparing agent. And it did work. And what we now realize, I think, is what we were doing was shifting that microbiome to that microbiome, but at the same time, we were selecting for resistance. And 20-something years later, we are where we are with resistance. And picking up Lisa's comments earlier about there is no knight on a white horse coming over the horizon to save us in terms of a new antibiotic. We have to get smarter about what we do. And I think thinking in terms of a dysbiosis and how we maintain a healthy microbiome will go a long way to reducing antibiotic use. Now, this again, some of this data was presented at the IACI meeting in Helsinki in 2017, and this again is a groundbreaking paper, and I'm going to distill several years of work now into about 2 slides. So apologies to the authors, but what they discovered was that some of these coagulase negative staphylococci exhibit anti-Staph aureus activity. So they produce antibacterial peptides specifically to inhibit Staph aureus, and they do this as part of niche competition on the skin and mucocutaneous junctions and so on. Now, what they discovered was that these anticoagulase, terminology gets a bit awkward here, but the anti-Staph aureus coagulase negative staphylococci, so the good guys, in green, were fairly prevalent in healthy individuals, but as you moved into atopic individuals, they were much less prevalent and quite rare in atopic lesional skin. So again, this was one, the authors speculated this is one reason for the failure of, or the failure to maintain a normal microbiome is because the healthy structure had been upset. Now, again, a great deal of experiments and a very long story short, what they did was isolated some of these staph, coagulase negative staph, and some of these were staph hominis and some were staph epidermidis, that showed good broad spectrum anti-Staph aureus activity, put them into an ointment vehicle, and then used them as what they called this autologous microbiome transplant. So this, and just in a small number of patients, this was the control group where there was no treatment. So again, the Staph aureus levels were quite high. And then in the placebo group, and then followed by the active group, there was a dramatic drop in the Staph aureus levels without using antibiotics. So this is something I think in the future is the way we're going to go in terms of managing microbiome rather than treating infection. And this was another paper, and this neatly sort of goes on to the idea of using topical antiseptics, because they used a stressed mouse model to replicate the changes in the microbiome that occur on human atopic skin. And again, wrong way. Basically, what they found is if you treat these mice with a topical antibiotic, you suppress everything. So you suppress the good coagulase negative staphylococci as well as the bad coagulase positive staphs. And what tended to happen is the Staph aureus ones bounced back quicker. So you got a temporary fix, but you didn't maintain the microbiome. But with topical antiseptics, what they found is it only reduced the very high coagulase positive staph populations and had much less effect on the overall microbiome. So I think a very strong argument to say that we should be, wherever possible, to manage these infections or this dysbiosis, moving towards using topical antiseptics and only reserving antibiotics where we absolutely have to use them. And again, this is looking at topical therapy. So this was using emollient, a couple of emollient preparations, and again looking at the microbiome. And what they found is those atopic patients that responded to emollient therapy showed a change in their microbiome from the staph skewing towards a much more diverse and even microbiome. Those patients who didn't respond maintained the coagulase positive staph population there. So suggesting that using an emollient, the one way emollients work is as prebiotics to change the microbiome to a more tolerant and healthy state. And again, this probably is going to vary a little bit between patients, though. Yeah. Oh, yeah. Emollient. It's basically Soothing. So it's substances that are moisturizing and soothing, so help repair the skin barrier, normalize epidermal lipid layers, normalize ceramide balance, things like that. Okay. Yep. And then showed you this slide at the beginning, but going back to some of these, and at the time, the authors, we didn't really know about the microbiome. But if you look at a lot of the susceptibility factors and the protective factors here, they may all be affecting the microbiome. And the microbiome can exert local local regulation on the immune system, so at the skin surface. But we're also beginning to understand now how the gut microbiome, for example, has a very important role to play in regulation of immunity at distant sites. And in humans, this has been proven to include the skin and the respiratory tract in asthmatic patients. This kind of put this slide in because, again, when I was a student and a young vet, it was drummed into me that in the face of infection, you should never use a potentially immunosuppressive compound. And I remember as a young dermatologist beginning to get fairly puzzled by this because, it was drummed in. If there is this secondary staph infection, we need to treat with antibiotics before we can move on to the steroids or a little bit later the cyclosporin. And I sometimes found myself chasing my tail because I was trying to treat this infection and waiting to use the anti-inflammatory and never really getting on top of it. And then I began to evolve my thinking and saying, well, why is that infection there? The infection or the dysbiosis is there because the skin is inflamed. Therefore, I started to switch. And, when I was doing this 10, 12 years ago, it was kind of heresy. But now people are beginning to get clever about thinking, why is that dysbiosis there? Treat the root cause of that and not just treat the end infection. And this was some work showing that steroids and cyclosporin don't really impact the cutaneous microbiome, the bacterial population. So what you can do is use those drugs to help normalize the skin barrier, normalize the inflammatory environment, and go some way to helping to preserve a healthy microbiome. So this is some of the things that we've talked about. So again, rather than treating infection and being wedded to this idea that we treat the infection, we give the cephalexin, the amoxiclav, hopefully not a fluoroquinolone, but it does happen, and it goes away, and then being mystified when it comes back again. And this is one of the things that leads to recurrent antibiotic use, which is a major driver for resistance. We need to think about why is that dysbiosis there, manage the primary factors, use proactive therapy to keep, once we've got it normal, keep it normal. Consider topical antiseptics, and you'll hear more about that later on this morning. I think in the future, prebiotics and probiotics are going to become more important. And again, Ceva have some interesting data on S3, which you'll hear about a bit later on in that regard. Maybe microbiome transplants for us in the future. And then certainly, I think the other thing is the microbiome is highly variable between individuals. So again, this is where we're going to have to treat every patient differently and individualize their treatment. Right, just a few things to finish up with that I said I've kind of pulled out because I see this happening all the time. And I do think making a diagnosis here, a firm diagnosis, is really important because we're looking at lifelong therapy with these dogs. I can't think of many other diseases where we will diagnose this in a 1 to 2 year old dog and still be treating them when they're 10 to 12 years old. And how we treat that is going to change over the evolution of the disease and the dog's lifespan as they start to develop other problems, particularly associated with old age. Now, this is the classic statement that's been made and approved by CADA and so on. And I think we need to nuance that slightly now because it does lead, in my experience, to over-testing which leads to complications, expense, and wasted time. And I think there are a few things that we can do to speed the diagnosis up a little bit. So I said it generally is a young disease. Now, interestingly, a food component, if they start with disease less than a year of age, they're statistically more likely to have a food component than if they start over a year of age, unless you're a French bulldog. I've seen French bulldogs start with this at 3 months of age. Are they very popular in the Nordic countries? Yeah, same with us. It's kind of the gift that keeps on giving, really. If I was cynical, I would just breed them and sell them to my clients. Because I can earn the money. They're astonishing amounts of money. They're going for the equivalent of, what about £1,500 to £2,000 in the UK? So, whatever that is in your various currencies. So I could make the profit on that and then just keep raking it in when they come back to me. Pollen allergies is something that we see reasonably frequently, not nearly as much as perennial disease, but I think if you're looking at pollen allergies, it is worth knowing what the pollen seasons are where you practice, because this has to make sense in terms of flares and exposure. And then the other thing is, if you suspect a seasonal component, try and test within or shortly after the season, because we do see animals where the level of antibody will drop off quite quickly outside of the pollen season, but the memory cells are still there. So when they come back in, they will quickly start to respond again. But if you test in the winter, you may get a false negative for the pollen. Now, this, I think, is a very strong relationship, in that the erythema here, in most cases, is diffuse. So what you see in the affected area is, in the early cases at least, is this diffuse pattern of erythema. Now, there are a few other diseases that will do that. Most of the differentials here will give you a macular papular pattern of erythema, which is the individual spots and patches of the color change. So if you're alert for that, it can really get you to a diagnosis. This is work from my PhD, so very old now. Kind of pleased to see that nobody's really trashed it yet. And this is these were allergen negative dogs. These were the allergen positive dogs. Really no difference between them. And you can see, that this is very much a disease of the ears, the muzzle, the feet, and the underside. Given nuancing now this with the breed variations that I showed you a little bit earlier on. But one fascinating thing about atopic dermatitis in dogs is how similar this is to atopic eczema in people. Given that in terms of mammals, we're not particularly closely related to dogs. But even if you morph, like one of those sort of Hollywood werewolf films, if you morph a human shape into a dog shape, it's the same areas of skin that are affected. So if you start to see a lot of flexor surface involvement, that's highly suggestive of atopic disease. And then atopic conjunctivitis, you can see this dog's a little bit this is an extreme case. Just put it there to shock people. That dog did okay, by the way. Don't have nightmares. But you see this dog's very slightly photophobic here. And there was a study from Ana Mafalda in Portugal showing that about 80% of her atopic dogs also had an atopic conjunctivitis. Now, no parasites or contact diseases are going to do that. So if you can rule out other causes of their conjunctivitis, then it strongly pushes you towards this atopic group. It also might need treatment as well. It can be quite uncomfortable for the dogs if it's missed. And then, again, otitis there would be very common. Rhinitis, pretty rare in my experience. But again, if I have a sneezing dog as well as an itchy dog, it's sliding me towards an atopic phenotype. I won't dwell on this because I'm sure you're all on top of it, but at least in dogs, doesn't help with cats and horses, but at least in dogs, the distribution of the parasites can really help you. And again, you're looking at this macular-papular erythema rather than the diffuse erythema. Now, this is a dog with pruritic demodex, which is reasonably common and is missed. And I'm sure nobody in the room does this, but I'm not saying you do it. But if you go and talk to other vets doing CPD, you can pass this on to them. We do see this pruritic demodex. People don't think about demodex as a pruritic disease, but if you see an itchy animal with a macular-papular dermatitis, where these papules are centered on the hair follicle, and you have comedones and follicular casts, then this is almost certainly demodicosis. It's a 30-second diagnosis, and you're straight onto it. Something I teach now young vets and students is to look in detail at the skin, understand what the skin is trying to tell you, because it really narrows your differentials down. So sarcoptic mange can affect the ears, the limbs, the face, underside of the body. So superficially sounds a lot like atopic dermatitis, but if you look at the skin, it'll have a macular-papular crusting dermatosis. It's the outside of the ear, not the underside. It tends to be the lateral limbs rather than the flexor surfaces. So again, if you look in detail at the skin, you can move sarcoptes up your differential list, or atopic disease, and it can speed you to the diagnosis and get the air much more efficiently. Chronic disease, again, doesn't really help us in terms of the diagnosis, but this is post-TICA. Our aim really is to stop this happening, because if that happens, we have failed as clinicians. Now, it might not be our fault. It could be the owner's not been listening to what we tell them. But this is what happens with time, and it's much, much harder to control. And in case of the ears, maybe irreversible as well. A couple of things to think about. Cutaneous lymphoma, again, it's very rare to see atopic dermatitis starting over the age of about 4 or 5. It does happen, but it's rare. So a newly itchy older dog, this is where I would biopsy sooner rather than later. But in most cases, biopsying an atopic dog won't help, because I could write the histopath report for you now, and then we could split the fee between us, because it would just be non-specific. So you need to target the histopath carefully. And then this is something to be alert for, and this is the odd, unusual case. So if the itching or the self-trauma, well, firstly, if they're mutilating rather than excoriating, so they're damaging subcutaneous structures, that would tend to suggest neuropathic disease, neuropathic pain, rather than just itch. If it's very focal, it tends to suggest this. If there's no inflammation other than that caused by the dog, it would tend to suggest this as well. So it's not particularly common, but they're ones to be alert for. We get some of these referred in all the time. I've seen dogs that are just traumatizing digits 4 and 5 on both hind limbs and nowhere else. And you think, that's not atopic. That has to be some sort of nerve pathway. So these are the slightly more challenging cases just to be alerted for. This one, we've kind of gone through some of this already. These are Claude Favreau's criteria. So that one I'd agree with. That one, I mean, it's very rare for me actually to see a dog that lives outside, possibly because they're not atopic, I suppose, you could argue. This one, I would certainly put Apoquel and Cytopoint in there now as a potential diagnostic criteria. That one certainly yes, although it is breed dependent. That one we'd agree with. That one we'd agree with. That one, again, we've got to be a little bit more careful now about the breed dependence. And interestingly, going back to that earlier slide I showed you, where the malassezia didn't appear to be particularly associated, changes in the fungal microbiome didn't appear to be particularly associated with atopic dermatitis, but a skew towards different malassezia were. And it's actually very rare for me to see malassezia in a non-atopic dog, because we tried to recruit some a while back and we really struggled with that. So it does seem to be an association there. This is what I teach now as the overlapping patterns of allergic sensitization. And again, I won't go into this in too much detail because you're going to have much more on testing and immunotherapy later on. But I've not overlapped these two because this is the allergen negative or environmental allergen negative form of the disease. This is the environmental allergen positive form of the disease. Food only, pure food reactions are rare in my experience. What we see more is where food is one component of the disease, either in combination with environmental allergy or by itself with that. And then we've got anxiety, which I think is underdiagnosed in animals, certainly cats and humans, a very important part of the disease. We've talked about skin barrier defects, environment, infections, and so on. So I'll spend a little bit of time talking about food because I think this has really changed in the way I do my practice in about the last 10 years or so. And one is I've begun to recognize much more of these partial food responders where food is a component of the disease, but it's only one trigger. So these are the food-induced atopic dermatitis dogs. And one of the problems is if you say to an owner, has your dog had any vomiting or diarrhea? Most of these owners will say no, because they have low-grade GI disease, and we have to use these very precise questions. So we actually ask these specifically now, and we also have a fecal score chart, which is charming. We use the Waltham 1 to 5 scale. It doesn't matter which one you use, to demonstrate the poor consistency or variable consistency of the feces. I used to have it on my office door when I was a resident, in our residence office, and we had "Rate Your Day" above it. And then one of the senior members of staff who had no sense of humour made us take it down because we were unprofessional on that. But this is important. You need to ask those specific questions, otherwise you might get misleading. Now, this is from one of the Akada position papers, which you can get from the website. And I don't know why this isn't a bigger scandal than it is. Most vets and pet owners are still unaware that, and in some of these studies, up to 80% of the tested foods had undeclared ingredients on the label. So this basically means now, if I'm trying to take a food history, I'm clueless. I have no idea what's actually been fed, neither has the owner, because even if they can remember it was Waggy's kibble with chicken, we've no idea what else was in there. And then the second thing is, if we're trying to choose a single protein diet, and many of these foods in the red bars here were single protein diets, we can't have any confidence in that for diagnosis and for long-term management. So it's really made things very difficult. And then the other problem we have is cross-reaction. So this is showing that chicken basically cross-reacts with duck and turkey, but not beef. And also, the chicken allergen seems to be very, very small. So if you want to abolish binding to chicken, you have to use this extensively hydrolyzed chicken meal, which is effectively what's in an allergenic. And then this is some work done by Jennifer Bexley, basically showing that beef and lamb cross-react, but not with turkey. And that makes evolutionary sense because mammals went off in one direction, and you had reptiles and dinosaurs and birds, split off hundreds of millions of years ago. They've had a long time to diverge, albeit some chicken-sensitive patients do cross-react with white fish as well. And so what we regard as exotic is not necessarily novel. So anything within the beef-lamb group, so goat, bison, water buffalo, buffalo, yak, whatever, is going to cross-react. And the same within the bird group. So anything that's within that chicken, duck, turkey group, so that includes swan and goose and guinea fowl and pheasant, is all going to cross-react. So we need to be thinking in terms of evolution when we're looking at novel foods there. Again, I'm kind of trying to find this paper, and I don't think Claude's actually published the full paper yet. If anybody knows different, let me know. But essentially what he showed, do you have a lot of raw food feeders in Nordic countries? Yeah, insane. I've just taken on a role as an advisor for a charity that basically gets dogs to visit elderly people or disabled people who, for whatever reason, can't now have a dog. And I've said no raw food feeding because we've had Salmonella, Listeria, Mycobacteria, and Campylobacter outbreaks associated with raw food feeding in the UK. And I'm not taking my neck on the block here. I'm not taking that risk, but I'm getting a lot of kickback and some abuse for that. But basically, he showed that raw food was as allergenic, as dry food, but cooking, wet processing seemed to knock some of the allergenicity down, and that's probably because of changes to or denaturing the allergen. And what happens with dry processing is you have this very high dry temperature processing, and that creates new glycoproteins, which brings the allergenicity back up again. So what that means in practical terms, I don't know. Okay, confession time. Hands up who allergy tests for food. Right. I don't know, again, I don't know Nordic countries. Almost every single referral I get has had one of these tests done. I have now started putting this slide up in CPD and saying, which one of these words is hard to understand? They are pretty useless in terms of their very, very low accuracy. We only really use these if we have an animal with a very restricted diet. So we've had some boxers that have been atopic, have also had renal dysplasia, for example, to give us a steer as to whether or not the renal food is okay. But otherwise, they're pretty useless. This is why I tend to use a lot of allergenic now. I showed you the data for the chicken meal for that. This is also a study done by Marie-Christine Carrière, showing that it was effectively equivalent to a home-cooked diet, and this was as novel as the company, the owners, could make it. And then this was work done by Thierry Olivry using chicken-sensitized dogs, and they showed that really they didn't respond. So same as the serology results, clinically they didn't respond to the fully hydrolyzed diet. Now there are other hydrolyzed diets available. There's Purina HA, that's soy-based. It has in humans, soy doesn't have to be hydrolyzed very far. They've assumed that that's true in dogs. We don't know that for sure. And there are some hydrolyzed fish diets available as well. Again, I don't know how far you have to hydrolyze fish before dogs stop recognizing it. So a little less evidence. Just to finish up, Malassezia hypersensitivity does exist. I think this is real. I think it can make a real contribution to the disease. And there is certainly evidence from Sweden and other Nordic countries, or was it just Sweden? Just Sweden then, showing that dogs that are atopic dogs that are monosensitized, so they're only sensitized to Malassezia, can have a good response to immunotherapy there. Whether that's true for staph, I don't yet know. It certainly is in people. This was some work showing that a number of the atopic dogs here had elevated levels of anti-staphylococcal IgE compared to the control groups. How clinically significant that is, we don't yet know, but it's something we'll be looking at for the future. So what I'm going to do in this half of the talk is go through some of the practical consequences of what we discussed in the first half, and hopefully bring some of that sort of background and the science that's been going on into explaining how and why different treatments work in different dogs and circumstances, and how we can pull this together to optimize treatment for each patient. And I keep mentioning the importance of this proactive treatment, and I'm going to be or it's kind of sat on my guilt pile at home, is I'm chairing the 2020 ICADA treatment guidelines. And one of the things we're going to really change is to look at proactive treatment, because I think those guidelines have been really successful. But in terms of talking about acute disease and chronic disease, we have maybe inadvertently pushed people to thinking about reactive treatment, about getting the crisis under control. And what's really important is this concept of proactive treatment. And I think this works on all sorts of levels, to do with the inflammation and the itch and the microbiome and the skin barrier. And what we want to do is take, and this is the same dog, some of my patients do get better. So what we need to do is take this dog, move it into this dog, but then keep it there. And traditionally, and partly this was driven because we didn't have safe long-term treatments, we were treating the flares. And I've kind of deliberately started to move that curve upwards, because I think we'd all agree that if we just move into that reactive treatment, with time, those flares become more frequent and more severe and harder to control. And if you think about it, this is the owner that comes to see me, and the ear canals are like that. And I'm stood there saying, I'm really sorry, but the next person you need to see is a soft tissue surgeon for a TICA. And the owner is mystified, because they say, but every ear infection we treated and it got better. And what we're not doing with reactive treatment is we're missing the ongoing changes. And this is what's driving the chronic change. So proactive treatment, I think, is something we're really going to emphasize in the 2020 guidelines. You heard it here first. What I'll do is go through, we haven't quite decided how we're going to do it, and I'll go through some models with you of factors we need to look at. Now, as I said, when I was a young man, we have very little to treat this disease: essential fatty acids, immunotherapy, steroids, weekend antibiotics. That's about your lot. And we've got loads now, loads and loads of different treatment options, and I'll go through these and how we can pull these together, and different models, as I said, for putting together proactive treatment programs. Now, I'm not going to talk much about immunotherapy, because you're going to get that this afternoon, except that I would say it is still highly recommended in the 2010 and 2015 guidelines, and almost certainly in the 2020 guidelines as well, because it is a safe, efficacious, long-term treatment that can be disease altering. And if you actually look very critically at the efficacy, and again, I'm simplifying this, but very roughly, you can say that most treatments, even the very effective treatments, are only working in about 70% of the cases. And that's about the same success rate you'll get with immunotherapy. So again, it's something I would encourage you to explore in your patients and tackle that allergic side of the disease, although bearing in mind it's much more complicated than just an allergy. Topical therapy is the mainstay. This is the first line, baseline treatment for human eczema, whether this is adult disease or childhood disease. It's the first thing that they major on. And one of the challenges we've had in veterinary practice has been some of the shampoos and products that we use have very little evidence to support their use. And really, up to this point, these were the only two with evidence to support their or show a benefit. And the benefit in terms of itch was about 25% reduction or so, and it was fairly transient. And one of the problems is, in humans, it's not that big a deal to build into our routine, because most of us, choose my words carefully here, most of us shower most days, or have a bath most days. So building in a topical product, and we're fairly hairless, some more than others, but anyway, that's another story. But this can be a big ask for owners, particularly during the week when they're very busy, to do these shampoos. But the intensity of the bathing is important, and this is where these mousse preparations have become very popular, because they're non-rinse, so they're very much easier for the owners to use in between the shampooing. And again, I'm not going to dwell on this, because you'll get the full story a little bit later on. But I think where S3 has the potential to revolutionize the way we look at topical treatment is in a number of ways. And firstly, it is one of the first products where there's been extensive screening of the constituent ingredients to cover the skin barrier, immunology, and the microbiome. So they're really those three key areas that we talked about in the first lecture. And again, this is some of the science behind the S3 products. So this is effects on the skin barrier function, effects on staph adherence and the microbiome. And again, this is a immune marker here. So I think, so firstly, I think it's gone right from the bench to the clinic. And then secondly, really, is the formulation of this. And now I have to confess here, when I was involved in the initial discussions around this product and designing the clinical trials, I was skeptical. And I will freely confess that I told them it wouldn't work. I'm happy to be wrong. So you've got this 3-week cycle of a shampoo and then 2 to 3 times a week the mousse. And certainly with the Pio product, I was deeply skeptical, and I said, "There's no way. There's, you're not onto a winner here." But I think it's got to be weekly shampoos, which would still be a step up from using the traditional products, and then the mousse in the middle. But say I was proved wrong. So the evidence is that with the new S3 protocol, you've got that 3-week cycle. And this is so much easier for the owners to do. So I think it's going to have a big impact on compliance and acceptance, and this will have a big impact on efficacy and quality of life. And as far as the Pio product is concerned, it could have a major impact on reducing antibiotic use by giving us better options there. Now the caveats to this are this was an open label, uncontrolled trial, so it wasn't blinded in any way. So the caveat is that there could be some degree of placebo effect here. But even so, and admittedly, again, ideally controlled studies would be done here. But this is the Cadesi 4 score. So this very much goes, they started off very much in the moderate range. And then there was a degree of improvement with the old protocol, which is kind of where we'd expect it to be, and a much more dramatic improvement in the lesion scores with the new protocol. And again, caveats, it was uncontrolled, but this is a reasonably objective scale. So we were pleasantly surprised with the efficacy of the product there. Nobody seen what I did there? Swapped out the flag. Might be the last chance I get to do it. So anyway, I put that up because you'll see that quote, and I'm happy. I'm pleased with the product. I'm happy for that to be used. So I'll stick my neck out for that one. But so you'll hear much more about that later on. There are these spot-on products that again are used to repair the skin barrier. The idea is that they have essential oils, or this one very much is more of an essential oil-based product, and this one is more of a sort of ceramide precursor type product. So the idea is you're repairing the epidermal lipid layer. The clinical trials and my own personal experience with those is that they're of limited, really quite limited benefit compared to the more intensive bathing models, and I think it probably makes some sense there with that. I'll move on. We talked about the importance of topical antiseptics. Now, there are lots of innovative products that are under development or under testing at the moment, but still really the one that has the best evidence to support its use is chlorhexidine. And in various clinical trials and in vitro studies, this has been shown to be highly effective, even against very antibiotic-resistant bacteria, such as MRSP, MRSA, Pseudomonas, and so on. And a couple of studies have shown that a twice-weekly intensive bathing model was as effective as using systemic amoxiclav in staph pseudointermedius infections, or as we now know, a dysbiosis. And I think the advantage of using these products is that you can get the staph, that elevated, unstable, skewed staph pseudointermedius population under control without having the same collateral damage that you have to the rest of the skin and other microbiomes that you would with using an antibiotic with that. And that's just to show that the chlorhexidine products have residual activity on the skin. So applying the sprays and the foams, you can show a persistent activity for several days. When you then take that hair and plate it up with the bacteria, you can show the zones of inhibition there, which is not true for most other antiseptics. Now, I talked a little bit about diet early on, and one of the things about diet is whenever we change the diet, we're actually having a much bigger effect on the body, and we might need to start taking a much more holistic approach when we think about diets. And we sometimes, I think, tend to have a sort of tunnel vision when considering diets, and we're really looking at the sort of novel protein and hydrolyzed protein. But a lot of these are essential fatty acid enriched, so we're potentially immunomodulating and having effects on the skin barrier. And then if we change the diet, we are likely to change gut health as well. And as I said earlier, there is increasing evidence from people and animal models that the state of the gut microbiome can have important modulating effects on inflammatory markers in the lung and in the skin and elsewhere. So I think sometimes when we see a non-specific response to the diet, we need to be thinking in a bigger picture. And just because it's not an allergen-mediated response doesn't mean that it's a bad thing with that. Now, topical glucocorticoids, again, are a mainstay of treatment in humans because, again, we're a relatively hairless species. It's easy to apply these things, and that's not necessarily true for our patients, although in most breeds, maybe German Shepherd, Westie, Shar-Pei aside, in most breeds, this is a relatively localized disease, and it tends to be localized to the less haired areas of skin. So topical treatment is entirely feasible. And this is related to humans. We don't quite have the same classification in veterinary practice, but basically, you've got the sort of least potent steroids down here, and then the kind of super potent steroids up here. And there's also variation on different parts of the body. And again, not overly surprising, the thinner the skin, the more likely you are to get systemic absorption. And in humans, there's very much an almost straight line relationship between safety and efficacy. So hydrocortisone down here is a very low potency product, but it's a very safe product to use, whereas clobetasol up here is a much more potent product, but there is a much greater risk of side effects. So traditionally, these sorts of steroids were used to induce remission, and then you would transition to these ones for long-term treatment. But this one is methylprednisolone acipinate, which is very similar to hydrocortisone acipinate. And what they've done is maintained the efficacy of betamethasone or triamcinolone there, but with the same safety as hydrocortisone. And so they've revolutionized the way we think about topical glucocorticoids. And this was some work that we did with Anna Mafalda in Lisbon, looking at using hydrocortisone acipinate as sole therapy. So again, this is not something we would particularly recommend because we weren't really treating the entire disease holistically. And if I could go back and do this trial now, what we did is treated them at the weekends. We got every dog into remission and then switched them to weekend therapy with the active, which was Cortevance at the time, or a placebo. And now I would do that twice a week rather than 5 days on, 2 days off. 5 days off, 2 days on. But even so, the median time to relapse here was over 100 days compared to the placebos that crashed out fairly quickly. So showing the benefit, one of the first studies to show the benefit of proactive treatment at that. And the safety was very good with that. Other things that you can do with topical glucocorticoids, really, they're incredibly useful products for treating focal areas of disease. So we use these a lot in ears, and we use them a lot in eyes as well. And I might mention, in case I forget to mention this a little bit later on, ears and eyes, and sometimes feet as well, I find are areas where you get chronic inflammation that is poorly managed by some of the more narrow spectrum treatment options we have, especially oclacitinib and lokivetmab, so Apoquel and Cytopoint. And where we're using those, we'll often combine them with a topical glucocorticoid to keep those areas under control. And one of the dangers is if we don't, the effect on the itch can mask the grumbling inflammation in the ears until it becomes catastrophic. So they're very useful products and very simple to use twice a week for that. These are the topical calcineurin inhibitors are not licensed for use in animals, but they seem to be very safe. And we use these a fair bit in dogs now. So there is a subset of atopic eczema in people called a protein contact allergy. Vets are at risk for this. Butchers, chefs, bakers, people like that. And I think we do see this in dogs, and we most commonly see it on the ventral abdomen, and it's dogs that become sensitized to non-pollen plant allergens. And using tacrolimus on that area of skin there can be very effective. We use it a lot on the feet as well, particularly with chronic inflammation. And cyclosporin is well known for treatment of keratoconjunctivitis sicca. I find that's a little bit low. It doesn't seem to work as well for the atopic conjunctivitis. So we can make up solutions of a higher concentration, but there are also now tacrolimus compounds for use in eyes, and I use those a fair bit as well. Now, moving on to the systemic drugs, and I still use a lot of steroid. Anybody else? Yeah, and the reason is, if you want something quick and broad spectrum, there is nothing else. Steroids, systemic steroids are your go-to, or topicals if it's localized disease, because they suppress everything. Now, if I can kind of use some military analogies here, so if you have say a civil war going on with the two sides fighting like that, the equivalent here is a heavily armed United Nations peacekeeping group moving directly in and forcibly separating those two sides, because they shut everything down very, very quickly. And that's why, if I need to get that under control quickly, that's what we do. And without any guilt there. So that's their advantage. Oops. The disadvantage is the problems with the long-term effects of this very broad spectrum of activity in terms of skin thinning, Cushing's disease, immunosuppression, and so on. But we use them a lot. Now, oclacitinib is also very rapid through its activity on the JAK1 and to a certain extent JAK2 receptor systems, because they'll block that receptor very quickly. So anything that's downstream from that will have its function turned off. And because that's the main receptor that IL-31 works through, this is why you get the very, very quick and rapid relief from pruritus. But and it will affect other cytokines that use the JAK1 pathway, but it is less broad spectrum than the steroids are, because it's not having the direct effects on the other cells to the same extent. So you get a very rapid relief from pruritus, sometimes a very rapid relief from acute inflammation, but it will have much less effect on chronic inflammation. So if you have an ear canal that's really swollen up, feet that are really swollen up, chronic change within the skin, it is probably not the best option there. But otherwise, we'll be quick. And this is the efficacy studies. So this is the lesion scores there, and this is the itch score. Now this to a certain extent, I'm kind of getting a little bit skeptical of some of these trials, because I think with careful case selection, you can show anything. But this one is a little bit more interesting, because what you get is that very rapid relief from the pruritus. Now, if these lesions here are mainly acute and mainly due to self-trauma from the pruritus, it's not surprising that you're going to get a mirroring of the reduction there. But what you see is this is the every 12-hour treatment, and then this is when you go to every 24-hour, and there's definitely a bounce back here before you reach a steady state again. Now, this bounce back can be for a number of reasons. One of these is that if you're blocking what you're doing with the JAK blockade is you're blocking the receptors. You're not actually blocking the production of the cytokines. You're not blocking the cells that are activated, the cells that are producing cell messengers, and so on. So if you take some of that blockade away by switching to every 24-hour medication or stopping medication, you can see the pruritus flare back, because for some time at least you've still got the mediators present there. And so one theory, and Thierry Olivier was talking about this at the Liverpool meeting, is could with some care, because it's not labeled for this, but would we get a better result is if we actually carried on the every 12-hour treatments for maybe a month? Because if we get rid of, if those cytokines and activated cells and messengers and so on go through their lifespan and disappear, we're not getting any new produced, you won't get that bounce back. We don't know for that. One possibility for this bounce back again is if you have some dogs where oclocitinib has a very short half-life, because remember, everybody's an individual, and when we say half-life, we really mean the average. Once-a-day medication might not be enough, because what's happening is they're flaring back in the second half of the day. And so actually long-term twice-daily medication may be appropriate in those cases, possibly with some dose adjustment, so trying to tweak the dose downwards, but obviously monitoring more carefully for side effects there. Now, one of the things that a lot of British vets have become, that's the word I'm looking for, there's some misunderstandings, is how Cytopoint and how Apoquel work. And a lot of British vets have sort of come away with the idea they're very similar. And it doesn't work like that, because although superficially they both work on this IL-31 pathway, and this is why they both have rapid effects on itch, Apoquel, as I said, blocks the JAK pathway here, mainly JAK1, but also has some, it's not absolute, it also has some JAK2 activity, and JAK3 and TYK2 activity, and that's when it starts to slide into immunosuppression and have effects on hematopoiesis, and that's probably variable between individual dogs as well, depending on the affinity between the oclocitinib and the receptor here. Whereas Cytopoint is a monoclonal antibody that just sucks the IL-31 out of circulation. So it works in a very different fashion. So this will have a broader spectrum of activity, because you have these other cytokines that also use this JAK-STAT pathway, whereas Cytopoint has very little effect on other cytokines other than the IL-31. So it's a very narrow spectrum agent, and it's very focused on itch and maybe some activity on early mild acute inflammation, but otherwise very, very focused on itch. But is probably very safe, because you're not affecting the other cytokines and other JAK-STAT pathways here. It's a very narrow spectrum like that. So in other words, because a dog that has failed to respond to Apoquel or has failed to tolerate Apoquel very well may still respond to Cytopoint, and vice versa. So they're not equivalent, although superficially they work on the same pathway. Now this is where the Cytopoint data gets a little bit interesting. So this is the itch score here, and this is cyclosporin, and this is the Cytopoint. So again, very rapid effect on itch, kind of not too surprised, and then you do get a sort of slower improvement longer term. You're probably down regulating all sorts of pathways there. And this is the cyclosporine, and not nearly as quick or an effective acting on itch. Not surprised, given the differences in the pathways there. The one that did surprise me, so this is the European Union label study showing that the effect on the lesions was similar between cyclosporine and Cytopoint. And I couldn't understand this. And if you look at the US label study, this is a slightly different graph. So the European dose is 1 milligram per kilogram, which actually, if you look at it, fits in just in there. So just slightly under the 2 milligram per kilogram mark. And this is percentage change. This isn't Cadesi score. This is change in Cadesi score. So basically, the further up this axis you are, the better. But even at 2 milligram per kilogram, and I said 1 milligram per kilogram slots in round about there, the Cadesi score really is only just scraping above 40%. So much less effective than in this study, where you're getting a much greater than 40% reduction, but it's quite variable, very wide error bars on this. And then this is some work that Thierry Oliver's group published very recently. And what they did is took their experimental atopic dog model and then did a challenge study. And what they showed is that, as expected, you had a very, very good response on itch, but almost no effect, except in one dog, but almost no effect on inflammation, which is much more what I'd expect. So I think the bulk of the evidence is moving towards saying that lokivatimab is a very narrow spectrum agent. It's a very safe agent to use. It has a very good impact on itch, but it is not a very good anti-inflammatory. And I think the data here probably reflects the fact that again, case selection, the inflammation here was probably associated, it was probably acute and probably associated with self-trauma. And if you take the self-trauma away, that inflammation is going to resolve. But these probably were not chronically inflamed cases on that. And this is the, again, another study by Thierry's group. And what they did here, so this is a proactive treatment again. And what they found is that just treating dogs with monthly lokivatimab Cytopoint injections at the 1 milligram per kilogram dose, they didn't really get much. So the median was just over 50 days in terms of remission before they crashed out with a flare. And that probably, again, reflects its very narrow spectrum of activity against the itch compared to the Cortevant study I showed you, which is a much more broad spectrum agent. Now, interestingly, they did get something about a quarter of their patients managed to get quite considerable long-term remission just using Cytopoint. So, very safe form of treatment, might be an expensive form of treatment, but a very safe form of treatment for and a long-term improvement. But I think you need to look at the case selection very carefully there with that. Just very quickly, because I'm starting to run out of time. We do see some of the animals here that could have crashed out through anti-drug antibody, because although this is genetically engineered to look like dog, there's still a little bit of it that is mouse, and 1 to 2% of dogs generate anti-drug antibodies to it. There are very rare reports of possible immune-mediated reactions, but they seem to be extremely rare. What seems to be more common is it just stops working because the immune system is just taking it out of circulation. So that's one reason. So cyclosporine, broad spectrum, because it inhibits the calcineurin in here, which has a large governs a large array of different pathways. So much broad spectrum activity compared to Apoquel or Cytopoint. Now, again, back to the Civil War analogy here, there is often a lag phase with this drug. And this is because it mainly acts on the lymphocytes. And the lymphocytes you could regard as the politicians or the generals who are way back from the front line. So this is like the UN sending 2 envoys to convince the people in charge to stop fighting. Once they agree, it takes time for the orders to filter down to the front line and for the two fighting sides to observe a ceasefire and disengage. So that's why, thank you. So that's why you see this lag phase. So there is some sense in combining this with a much more rapidly acting drug. So say a glucocorticoid if you need that broad spectrum of activity, or Apoquel if you can get away with targeting more towards itch and milder inflammation before you start the cyclosporin, and try and start the cyclosporin from a clean sheet, as it were. And certainly up to 3 weeks treatment, concurrent treatment with steroid and Apoquel has been shown to be safe with that. So is that kind of reproduced okay-ish or readable in the notes? Hope so. Or you can take photos, I'll leave it up for a bit. So this is a table that I've tried to put together, and I won't, for the sake of time, I won't go through this in detail, but it's something I've been toying with, and it's just a kind of little aid memoir to say, these are the advantages and disadvantages, and this is where I need to target, or these are the sorts of cases that I need to be thinking about in terms of targeting treatment. And I think Mette is going to go through some cases later on this afternoon with you. Everybody's taken a photo if they're happy? Yeah, move on. So this, is this still available in Nordic countries? It's Retinil. Yeah, it's just been withdrawn off the UK market for some reason. I like to blame Brexit, but we've stockpiled under advice from somebody who actually works for the government a month's worth of toilet roll, because apparently the UK imports all its toilet roll. That's the sort of Brexit crisis I could live without. So these work on, you won't get high from it. It's not that cannabinoid receptor. So it doesn't need to go in the dangerous drugs cabinet, but it works on inflammatory pathways. So it works on itch receptors and inflammatory pathways. It's very safe. The effects are somewhat marginal. Again, these were mildly affected dogs. You are seeing some impact on lesion scores, pruritus, and that's quality of life. That's not quality of life going down. A lower score is better under this scale. So you did see some improvement. We mainly use this as an adjunct alongside other treatments. And the same with essential fatty acids. There are a couple of very good studies. This was one of the early and kind of really groundbreaking studies from Bentesevic. Is Bente here? No. And colleagues, and again, based in the Nordic countries, and showing that you could get a 50% reduction in steroid use. And then Ralph Muller showed with this product, you got a similar reduction in cyclosporin use. So very good as adjunct therapy, is very safe. You can do this in diet or with supplements, but not effective on their own. Now, these are just going to go through some ideas about how we're beginning to think about how we put these treatment options together now, and how we better put together the treatment guidelines. And this is one way to look at it, in that when you are presented with the case, the first time you see it, your aim really is to get the dog into remission. So this is the reactive therapy. And what Thierry and Franny have been advocating here is that you look at the balance of itch and inflammation and target your treatments appropriately. And if you have a dog whose skin is only mildly inflamed or is relatively normal, but they're very itchy, then that's when you can use these narrow spectrum or more narrow spectrum drugs such as oclacitinib. You could probably put cytopoint in here as well. But if you've got a heavily inflamed skin like this, then that's where the glucocorticoids become the go-to, because they're the only thing that is going to work rapidly to control that severe inflammation. And if we don't, so if we take the itch away from here but not the inflammation, we're not addressing the microbiome, the skin barrier, ongoing cytokine production, and so on. So we might mask things for a while, but then it could come round and explode later on. And then what we're then looking at the proactive therapy. So this is get them in remission and then keep them in remission. Now, I, with my clients now, tend to sound like a broken record in that every time they come and see me, I tell them two things. One is that your dog's disease is lifelong. I cannot cure it. The second is we need to keep going with very regular therapy. Because if we stop, it's going to flare back again. And most of them very slowly will get that message if we keep repeating it often enough. And again, this is where we need to look at what we're dealing with. So are we at the more inflammatory end of things or the less inflammatory end of things? And this is where we need to be targeting the broader spectrum drugs, and this is where we can target more drugs with more specific activity. And again, during the disease process, we may be able to go from here to here, which means that we're changing the management. And this is why keeping in touch with your clients is so important. And I guess, if you didn't like skin disease, you wouldn't be here. But, if there's somebody in the practice who's, shit hot on orthopedic surgery, but hates dealing with people with pets with chronic disease, you need to be sliding those cases to you because those dogs and those owners deserve that level of attention and support and backup on there. Now, this is something I try to do in terms of what we call laddering, and this is used a lot in human dermatology or medical dermatology. But the disadvantage here is when I was starting to try and do this, I was going, but because again, every case is an individual. And this is why I think, you need to be in charge of the whole process. But again, my baseline disease is the emollients. We talked about those earlier, the topicals, essential fatty acids, holistic approach to diet, allergen avoidance and immunotherapy, which you'll hear about this afternoon, the retinol, and the cannabinoids in there, and maybe antihistamines. And I've put those in brackets because, again, they're very narrow spectrum. They only target histamine or H1 receptors. Histamine's very short-acting. You need to be proactive. If you're going to use antihistamines, you need to be proactively treating with them. The efficacy is poor. Target case selection becomes important there. But as we get more severe disease, we can be looking at the topical glucocorticoids, particularly for local disease there, the anti-itch mediators, again, put antihistamines in brackets, so they're not really very good for reactive therapy. But the proactive therapy, the glucocorticoids, and again, I'm building in the more broad spectrum drugs here. And then when we have severe inflammatory disease, really, again, these are much less effective, and we're looking at the broad spectrum agents. Now, again, what we're trying to do is move the patient down the ladder and then keep them there with very regular therapy. And what I would do is just emphasize again the very, very useful role of these products because of their safety. And as I said right at the beginning, you diagnose this disease in an animal age 1-2 years maybe, and you could be treating it till it's 10 or 12 or older, which means all the comorbidities associated with old age come into play. And I was talking to some folk at the break saying that holistic therapy has very much been overtaken by the alternative medicine group. And I think we need to recapture that term because we should all be practicing holistically all the time, bearing in mind the animal's neoplasia, liver disease, kidney disease, arthritis, and all the other ills that old age brings. So again, this is where the disease will change. So for example, we might have a dog who's very, very happy on Apoquel or cyclosporin, but if it develops neoplasia, we have to change what we're doing. And again, switching that to the Cytopoint, but then building in something topical and more broad spectrum to target the inflammation in the affected skin can be very effective and very safe. But this is the life cycle management of these atopic dogs, and realizing it changes through their age. Yep. Calcineurin inhibitor. So basically, I didn't have a room on the table to put cyclosporin or tacrolimus in here, but that's what they are. So it's CNI is calcineurin inhibitor, and that class of drug, basically, as far as we're concerned, it's cyclosporin and tacrolimus. There are some others, we don't really use them in animals. GCs there is glucocorticoids on that. And then just to really wrap up very briefly, there is more interest in more targeted phosphodiesterase inhibitors. Some of these are being used in humans for topical. This is the one we use a little bit in atopic dermatitis. Again, very safe for long-term use. Interferons I don't use very much. We tend to be using these mainly for our more difficult cases. The evidence is somewhat questionable on that. I think, again, this is very, very early, but in itch clinics, this is something that in human medical itch clinics, they're really looking at. Now, one of the problems we have is if I go to an itch clinic, I'll say, the itch is here, the itch feels like this, it's worse at night. And the doctor will say, right, well, you need this drug because it's likely this pathway is being activated. I mean, Dr. Dolittle is fiction. Our dogs cannot talk to us like that. So sometimes we're using these things somewhat speculatively or with a bit of a trial and error approach. But if you've got tough to manage cases, these are very worth considering there on that. Again, very, very difficult to manage cases. I have used some methotrexate with that. Again, you'd be looking at the more inflammatory forms of disease here. They're just not responding to the usual forms of therapy. And then that basically, again, is just a kind of quick summary slide to think about the different options that we have. And it's another way of looking at programs of treatment, because what we're aiming to do is try and have a program of treatment that targets the microbiome, targets the barrier, targets inflammation, targets pruritus, but in an integrated fashion that takes into account the stage of disease, individual variation, and lifestyle of and life stage of the disease as well. So I'd say we haven't fully decided how we're going to look at the new guidelines, but these are some of the factors that we need to think about. And I'll finish there. Thank you. Yeah. Yeah.
Did you have a quick question there too? Vitamin E?
Vitamin E, no. There was really early papers suggesting it might be of benefit. When I was a resident, we did try it in a number of dogs. We tried it for discoid lupus. We tried it for systemic lupus onychodystrophy. I think it was about it. My experience was very poor with it. Yeah. Okay, I'm not familiar with that.
Mm.
I mean, there's a number of things I didn't put on. So there's some interest in vitamin D as well. That, in a small study, did seem to help ameliorate atopic dermatitis. And there's again, mainly from humans, but also from other inflammatory disease in dogs, there is increasing evidence to suggest that deficiencies in vitamin D are involved in lots of different inflammatory and regulatory pathways. And certainly, I don't know about Denmark, but in Scotland now, it's recommended everybody takes vitamin D through the winter, the autumn and winter, and people with dark skin should take it all year round, because it's been shown that, I'm okay, but people with dark skin, we just do not we do not have enough intensity of sunlight because of our latitude for them to generate enough vitamin D. So it's now recommended they take it all year round.